All right, let's get started. So we're doing semester 2 today. This is the lower extremities. Again, it's going to be very similar to the upper extremities in terms of the terminology, the anatomical planes, but obviously there's inherent differences as well, and we're going to touch upon that right now. So we're going to be talking about lower limb function. We're going to be talking about the osteology, so the bones, and we're also going to be talking about the pelvis. We're also going to get into a bit of the lumbosacral plexus as well as the ligaments of the hip. I don't want to go into too much detail for that because it can get really confusing. What we'll do is we'll just stick with just the general aspects of that and see where that takes us. So I don't know if you guys remember from semester 1, but I kind of refrained from teaching the brachial plexus because it was way too detailed. The brachial plexus is way too detailed, and I found that it just would have been draining to teach that to everyone. So we're going to try the lumbosacral plexus today, which isn't as complex. And I'm not going to get into too much detail, but just to kind of show you how this nerve structure looks like in the lower extremity and give you kind of some clinical implications as to what happens with these nerves as well. So let's get started. Let's first talk about the design of the lower limb. And we're going to compare it to the upper limb as well. One major comparison, actually, and we're going to talk about this as well, is that think of the hip joint as the shoulder joint. They're the same type of joint. They're a ball and socket joint. So this is where the head of what we call the femur attaches to the acetabular, which is what we're going to talk about later. But think of the hip as the shoulder. Think of the knee kind of analogous to the elbow, and the ankle analogous to the wrist joint, and the foot analogous to the hand. So very similar in terms of developmental structure. Okay. We know that as human beings, we're bipedal, meaning we walk on 2 feet. We don't walk on our hands. Naturally, at least we could if we elect to, but we don't naturally walk on all 4 limbs. We walk on 2 limbs, right? So just my first question to you guys to kind of make sure everyone's awake is, can you guys think of any other animals that are bipedal in nature in terms of locomotion? So walking on just 2 limbs. And it has to be something they naturally do. So some animals can do it, but what are some animals that actually do it? So, okay, I already have a few answers. I would say you guys are, yeah, good. You guys are all really correct. So apes, monkeys, they both walk on 4, so they're quadrupedal. I think that's the term, quadpedal. But in any case, interesting fact about apes and monkeys is that if they were to injure their arms, they would actually walk on their feet. They would be able to do that. Kangaroos, good. Kangaroos are bipedal. Birds, yep. You guys got that pretty quickly, which is really good. Those are all the answers I had, actually. Let me see if I had any other answers. Ostrich, kangaroo, birds, chimpanzees when they hurt their arms. Yeah, you guys literally got all the answers. That's awesome. Yeah, so we're not the only bipedal animal, which some people often think we are. There are other animals that do it. We just do it really well. Yeah, so we're bipedal, and that means we walk. So gait refers to walking cycle, or sorry, gait refers to kind of like the movement pattern we have with our 2 legs. So gait can be walking, jogging, running, jumping. We do all those things. If you look at the thigh, you'll notice that we have quite a bit of an angle. So our thigh consists of the femur bone, which is this bone over here. And it doesn't go straight down as people would assume. It actually causes an oblique angle like this. We call that angle the Q angle. Okay. And an interesting thing about this angle is that women tend to have a larger angle because their pelvises or their pelvi are wider. Okay. And then eventually we'll talk about the clinical implications of having a bigger Q angle and how that affects the knee. All right. Now, another big difference between the lower extremities and the upper extremities is that the lower extremities have larger bones and hence larger muscles. we can generate way more force using our thighs and our arms, let's say, right? And if you go into the knee portion, another thing that's interesting is that there's very minimal flesh over here. So the front of the knee, we know there's a kneecap, the back of it, there's not much muscle here. You'll have some tendons. There's obviously the bone and the cartilage of the joints. You have some arteries that pass down the knees as well, but not a lot of muscular flesh through here. And then you go down to the shin, and we got the muscles of the calves, of course. We'll talk about these two bones in a bit. But if you look at the foot, unlike the hand, our foot actually bends at a 90-degree angle, whereas our hands remain in a neutral 180-degree angle. And that's kind of what differentiates the two. It's anatomically built to withstand our entire body weight, right? So because of that, the foot has a lot of adaptations to accommodate that through the heel pad as well as the plantar fascia, which we'll get into one of the last lectures for semester 2. But just something to keep in mind. These are kind of some of the main differences between the upper body and the lower body. Just some things to think about. So let's get to the osteology part of things. Let's start from the top, guys. So the sacrum, if you guys remember, is the end portion of the spinal column, right? We have the sacrum over here, and then the coccyx is that tailbone, that last little bit of spinal column. So that's over here. And if you look at the edges of it, so to the lateral parts of the sacrum, you'll see the innominate. And the innominate is another fancy way of saying the pelvis bone. We have actually two pelvi. We have a hemipelvi over here, hemipelvi over here, and they both join each other. So it's not one continuous bone. They're actually two separate parts, but they unite with the sacrum, kind of like a lock and key. Fits really perfectly. Okay. And again, that tailbone, the coccyx, is that last piece. It's close to the external anal sphincter, aka kind of like where you would poop from. That's where you would locate that. And it's also an area that commonly breaks when you fall on your butt really hard. So this is a common area of fracture if you were to fall on your butt really hard. So that's that. Now moving a little bit more laterally again. So we're looking at the innominate. The innominate is actually a collection of 3 different bones that form through puberty. And we'll talk about that in a bit, the different divisions of the innominates. But yeah, now we're going to go further down over here. Actually, you know what? Let's talk about the joint that connects the innominate to the sacrum. So between the sacrum and the innominate is the sacroiliac joint. You see that line over there, guys? Or this square over here, kind of within that square. You'll see a line. That's the joint that connects the sacrum to the innominate. And it's a very stable joint. You can imagine why. A lot of our body weight has to be stabilized through here. It doesn't move much, guys. It's a joint, but it doesn't move much. Now, there are certain instances where it does move, one of them being injury. If you injure your sacroiliac joint, it will move. Okay, that's not a good thing. You don't want this joint to move much. When you actually do want it to move is through childbirth. So during pregnancy, what the body does is it releases a hormone called relaxin. And it's released generally throughout the body. It has a non-specific kind of action where it loosens up all the joints of the body. But one of the main purposes of relaxin is to loosen up the sacroiliac joint. Now, why do you think that's important for pregnancy? Well, let's see if we can get some answers over here. What has to happen through pregnancy? I guess it's pretty obvious, but let's get some answers for that one. And you guys are quick today. I like it. Hips need to move apart to make space for baby. A baby needs to come out. Birth, awesome. You guys are on point today. I love it. Yeah, so that's where the birth canal is. So we'll talk about a bit more about that later in the lecture, but the sacroiliac joint over here has to move apart to create more space for that baby to be delivered. Okay. So let's move a little bit more distal and we get into the hip joint over here. And this is where the femur bone interacts with the innominate bone, the pelvis. Okay. And I talked about it earlier, but this is a ball and socket joint. We're going to talk about it later as well, but just remember that that's pretty much when we say the hip, we're talking about this joint over here. Now, if you move further distally, we get into the knee portion and we get into the patella. The patella is a kneecap. Um, it's kind of the intermediate bone between the quads of the thigh and the tibia of the leg. So it runs continuous with the quad muscles, which we're going to talk about later in the semester. And the quad tendon attaches to the patella, and then it's continuous with the patellar ligament that attaches to the tibia. Anyways, I don't even know why I got into that much detail. We'll talk about it later. But the patella is over here. Now, people often don't know what the purpose of the patella or the kneecap is. So what I did was I found a video to kind of explain. Its main purpose is to act as a fulcrum to make the knee joint an effective lever. So I'm gonna see if you guys can watch this video for now. Let me know if you can't hear it though. Okay, so I'm just gonna have the participants here. Let's get the chat over here. All right, we're gonna play it over here. So can you guys hear that? Just gonna check real quick. Can you guys hear that video? No? No? Okay. So, So I still haven't figured out Zoom properly. Let's see if I can. I'm gonna try one more time, guys, and let me know if you hear it, okay? Still no. Okay, major fail. No worries. What I'll do, guys, is I'll send a link to you afterwards, or actually I'll send a link to you right now through the chat and you guys can check it out later. All this video is really showing. I'll actually explain the video. Let me explain the video. So share computer, check share computer sound under share screen. Oh, wow. Oh, what the heck? Yeah, I see. I think I might have to like change the settings a bit. I'll give it a try, guys. Sorry, give me a second, guys. I'm gonna give this a try. Let's see. All right, guys, let's give this a try. No, you know what? I don't think it's gonna work, guys. Can you still hear me though? Like, can everyone hear me? Yes? Okay, perfect. Awesome. Yeah, you know what, guys? Let me just explain the video. I thought this would be a lot easier, but I'm gonna turn the volume down. So basically what they're doing is the guy's pulling on what would be the quadricep, which is this band over here. Over here is a shin bone, and you can see that when you have this little bone over here, when you have this little rock over here on the knee, it makes it an effective lever. But without that little rock or little knee part, kneecap part, when he pulls, he doesn't have an effective lever anymore, and it's a lot harder to extend this joint, right? So that's what the kneecap kind of functions as. It's this fulcrum. So he's going to attach it again. He's going to have the muscles go over it, aka the elastic band. He's going to cause a contraction to occur again. And you'll see that it takes very little force now to allow this joint to extend. So that's basically what the patella is doing. It's just becoming an effective fulcrum. It creates an effective fulcrum for the knee joint to act. And here they kind of show the difference between the two. I mean, eventually, if he pulls hard enough, he will be able to cause his joint to extend. But the video is trying to highlight that the body's very smart in the sense that it creates things to make things easier for us. Cool. Alrighty. So that's the patella. Now we get into the shin area over here, and you'll notice that we have two separate bones. We have the tibia, which is a lot thicker, and we have the fibula over here. So the tibia is medial to the fibula. Okay. Now, unlike so think of this as analogous to the radius in the ulna of our hand, right? But unlike the radius in the ulna of our hand, our tibia and fibula don't actually allow us to pronate or supinate, right? They don't do that. And then another interesting thing about this is that if you look at the knee joint itself, all the weight is actually being placed on the tibia. The tibia is the one surface that accepts all the weight. The fibula doesn't connect with the femur. It only joins up with the tibia over here, okay? And if you look to the right over here, the fibula and the tibia attach both superiorly and distally over here. So they have two attachment points, both of which are important for our function. We're going to talk about later. But for now, just know that the fibula is the skinnier one, tibia, bigger one. It's bigger because it has to accept all the body weights. And then we get into the foot region over here. And you guys obviously remember the carpal bones because that was the last lecture we talked about. And that was the wrist bones. Over here, we got the tarsals. And those are kind of like analogous to the carpals of the wrist. So we have many tarsals that we're going to talk about. And then we also have the metatarsals and the phalanges, which are like the fingers. Sorry, the toes. I said fingers, the toes. I always get those mixed up. And we're going to get into more detail later. Okay. So that's kind of the general osteology of the lower extremity. So let's get into a little bit more development now. Weird diagram, but once I explain it, it'll make a little more sense. So, you know, early in childbirth, we're this little bud over here, and we got two small buds come out, right? And when the limbs originate, they originate laterally. So they grow out sideways. So they start as these little buds and they grow out more and more laterally. The next step of development of our limbs is that they bend anteriorly towards the front of the body. So they bend forward, right? That's the next step of development for these limbs. Okay. The next step is that the joints start developing. So at the top over here would be the early elbow. At the bottom over here would be the early knee joint. Okay. Now, the things that kind of cause a difference in the elbow and the knee is the last step. And that's what happens when rotation occurs. So at this step, you have joints that have now formed, allowing the rotation to occur. The rotation of the upper limb happens in one direction. The rotation in the lower limb happens in the other direction. And because of this, it puts the knee in a position where when it bends posteriorly, it bends backwards. Whereas when the elbow bends, it bends anteriorly, it bends forward. Okay. So that's kind of like a brief idea of how development occurs to create these limbs of ours. And you can see, like, based on their origins, they're actually very similar. It's literally that last step of the rotation that creates the difference between the elbow and the knee. Okay, so I think the next two slides are where I want you to call, I put os coxae over here. Call it the pelvis, man. I don't even like the name os coxae. I don't know why I left it. It's another name for the pelvis. We'll just keep pelvis. I prefer that name. I think it's just because it's so ubiquitous. Everyone knows what the pelvis is. So we'll call it the pelvis, okay? So whenever you guys get a chance, just fix that in your slide. This is basically the area where our lower limbs hold on to. Another name for the pelvis is the innominate bone or the os coxae. Now, the pelvis itself is a very, very strong bone because at any time during locomotion, aka walking, running, jogging, jumping, it must support our whole entire body weight. And especially during like jogging or running, it must support all of our body weight on one lower limb. So when we walk, most of our walk includes, sorry, let me rephrase that. Scratch what I just said. Sorry to confuse you guys. So it supports our entire body weight, right? And when we walk, run, or jog, only one foot is on the ground at the same time for the most part. So all of our weight has to be supported on one side of our pelvis. So you can imagine the pelvis has to be a very, very strong bone. And when you go from walking to jogging to running, the weight or the force that's experienced on the pelvis actually increases, right? So if you have, let's say, a certain amount of force on the pelvis when you're walking, when you start walking, you're starting to generate increased power. Because of that, the pelvis actually actually experience more weight as you move faster, right? And then when you start running, it's even more because now you're creating more force between you and the ground. So pelvis, because of that, the pelvis has to be a super strong bone. And we talked about that sacroiliac joint having to be a very strong joint. Okay. Now, the pelvis bone itself comprises of three separate bones that were fused over development. So at the top here, we have the ilium. It's this big kind of wing over here. And then you get to the ischium, which is this part over here. And then the pubis will kind of be right over here. And I'll kind of show you a diagram later on how it looks. But if you look at the right diagram over here, you'll see how kind of they separate from each other. So number one over here is our sacrum. That's the bottom of our vertebral column. Number two over here is our ilium. So that's in this teal color. Number four is our pubis. So you can kind of see how it borders off with the ilium superiorly. And then it borders off with the ischium over here as well, which is in brown. Okay. The sacrum is at quite an angle too. So this is a sacrum in a human body that's standing. So we have to think of the spine as a straight structure. It's actually super curved. And if you remember from way back in semester one, we talked about how the vertebral column looks. We talked about how the cervix has more of an extended posture. Then we got into the thorax, the thoracic spine, which was more flexed. We got into the lumbar spine, which was extended, and then we got into the sacrum, which is a continuum of that extension. So if you were to stand up straight, this is how your sacrum will look. It's on average a 60-degree angle from the floor. So a lot of extension happens here. Now, one question I have for you guys right now is, do you guys remember what sits atop of the sacrum? So we see what's sitting, laterally to it. So we got the ilium of the pelvis that sits lateral to the sacrum. Do you guys remember what sits on top of the sacrum over here? What bony structure sits on top? And you'll get bonus points if you're more specific. So let's see in the answers what you guys think. Good, good. Good, good. Okay, awesome answers. I'm gonna wait for a few more. Let's see if we're all in general agreement. Awesome. Okay. So the general consensus is that it's the lumbar vertebra, particularly L5. So L5 was what I was looking for. You guys are awesome. In terms of the xiphoid process, the xiphoid process is actually the bottom of the sternum. So if you remember that we were talking about the sternum, we had the manubrium, we had the sternal body, and then we had the xiphoid process, which is that kind of soft part underneath your rib that you can kind of press in. It's kind of cartilaginous. That's where the xiphoid process would be. But in any case, you guys are good. So yeah, L5 sits on top of the sacrum over here. Awesome. All right. Now let's look at the lateral view of the pelvis. So we're looking at one side of the pelvis. We're looking at the outside of it. In this view, you can now clearly see the three divisions of the pelvis in different colors. The pubis is the anterior aspect. So the right is the anterior, the left over here is the posterior. So in the anterior aspect of the pelvis, we see the pubis bone. Okay. If you kind of want to get perspective as to where it is with respect to your bodies, if you were to wear a belt, the pubis would be felt right underneath where that belt would be sitting. Okay. So that's where the pubis would be. Now the ischium is in blue over here. To get a reference as to where the ischium is, I'm assuming most of you guys are sitting right now. You're actually sitting on your ischium. So if you were to move the muscular layers in your butt, you would be exposing your ischial tuberosity, which is this structure over here. We call it the sitting bone. Okay, that's the ischium. Now, the superior most aspect of the pelvis is the ilium. Okay, and if you guys want a reference to where this is, it would basically be what your belt would be surrounding laterally, right? So the outside of your belt would kind of be strapping around that ilium, especially that iliac crest over here. Or, you guys have heard of love handles, right? So it would be kind of underneath where most people would have love handles. That's where the ilium would be, just to get a reference point. Now, within these structures too, we have a few things to talk about. So we got the notches over here. We got the greater sciatic notch and we got the lesser sciatic notch. These are both ways for kind of arteries and blood vessels to kind of course through. And we got a question here. Is the iliac crest the same as a hip crease? Very good question. Let me Google that because I actually don't know. Hip crease. I think when you say crease, it would be kind of like an indentation of where the skin fold would be. Anytime I think of a crease, at least. Hip crease. Based on my Google search, it wouldn't be. The iliac crest would be more superior. The hip crease would be presumably where the AIIS is, which is what I'm going to talk about in a bit, the anterior inferior iliac spine. But for now, yeah, it doesn't look like the hip crease is there. So just think of where the belts would go, or maybe where the love handles would be. It's like that bony most part on the sides of your hips, guys. So if you guys can kind of feel your hips, yeah, a little bit higher. You feel like kind of like that bony part to the top of your hip. That's where the iliac crest is. That would be part of your ilium. So yeah, so we got the greater sciatic notch and the lesser. And there is a ligament that kind of connects the two over here too. And when the ligament connects these two ends, it becomes a foramen. It becomes a hole. We'll talk about that later. But this is just for your reference, guys. And over here, we got something known, I didn't label it for some reason, but this hole over here is called the obturator foramen. It's a hole right underneath this structure over here called the acetabular. It's another place for nerves and blood vessels to pass through in the lower extremities. And this is created by the unity between the ischium and the pubis. And we got one on both sides. And the acetabulum is the last thing over here. And this is kind of analogous to the glenoid fossa of the shoulder. If you guys remember the glenoid fossa, this is kind of the glenoid fossa of the hip. So this is the acetabulum. This is where the head of the femur. So if we go up a slide, this is where that head of the femur would attach to the pelvis, right about here. Okay. All right. So now we're looking at an anterior superior view. So we're not looking straight at the front of the pelvis anymore. We're kind of looking over top it to some extent, if that makes sense. Okay, just so we can see the structures that kind of go through it as well. So the topmost structure over here is that iliac crest that I was talking about earlier. That's that very bony part at the sides of your hips. It's also a very common place to take bone from if you need to use that bone for surgery elsewhere. Right, guys? So because we have so much thick bone over here, we use it as a place to transfer bone from one part of the body to another. So for example, if you were to break your jaw, the most likely place for a surgeon to go to get, bone from another part of your body is here, the iliac crest. There's just so much dense bone over here. And obviously it has a very protective function for our spine as well as our reproductive organs. So that's why we have this huge protection over here. And a lot of nerves course through here too. Now, if we go a little bit more inferiorly, we get to a point known as the anterior superior iliac spine, aka ASIS. And I'm saying it slowly because it's a mouthful of a name. I didn't write the full name because I couldn't fit it. So what I'm going to do is write the name of it over here. Anterior superior iliac ASIS for short. So for this structure specifically, we like to use the acronym a lot because it's just, oh, did I send that privately? Oops, there we go. I'll send it again, guys. So that's the ASIS. And if we have a superior aspect, we definitely have an inferior aspect. So the AIIS is the anterior inferior iliac spine. So let me write that one down. Right? So that would be this portion over here. And spines are like those protrusions in the bone that serve as great places for muscles and tendons to attach, if you guys remember from semester 1. So those are two prominent little spines that are in the anterior aspect of our pelvis. Now, if you look a little bit further down, we get what is known as the pubic tubercle. So tubercle is more of a bump. It's a bump that's found on the pubis bone, which is that, front portion of the pelvis. And if you see this red line over here, I've attached a red line between the pubic tubercle and the ASIS. And that would be presumably where we'd have our inguinal ligament. And for some reason, I did not label that either. Sorry, guys. Here, let me write that down. Inguinal ligament. And this inguinal ligament has a lot of clinical significance. One of them being that a lot of important structures run through or underneath the inguinal ligament, including veins, arteries, and nerves. It's a very common place to get a hernia as well. So a couple of my clients specifically deal with an inguinal hernia, and it's basically a hernia that's caused either above or below this inguinal ligament over here. Okay. Now, if we go even further down, we see rami of the pubis. So rami, I think, is another way of saying arm. And we got these two arms over here. We call them the rami of the pubis. And if you look medially at the medialmost portion, these two rami of the pubis from the right and the left, they form together over here. in a unique joint called the pubic symphysis. Okay. And it's a very, very strong joint as well. I mean, if this joint was damaged, you'd be in a lot of trouble. And of course, this circle over here is that obturator foramen that we were talking about in the previous slide. So that's that same circle as we saw over here. And oh, wow, I didn't label a lot of things, guys. Sorry. Obturator foramen. Nope. Obturator foramen. So in that, red circle over here is the obturator foramen. And again, a lot of important structures run through here. Sorry, guys. I know first lecture of semester 2, and I'm already not labeling everything. Great. I will make sure lecture 2 will be a little bit better. And the last thing, which I also didn't label, is the pubic. No, I did. No, I didn't. The last thing over here is the pubic arch, and it's right below the pubic symphysis. It also has a lot of clinical significance that we're going to talk about in a bit. Let me write it down over here. Pubic arch. So that's that hemicircle over here, guys, okay? Awesome. Alrighty. So now we're looking at a superior view. So thanks, Zaid. We definitely all are humans. I know. But I'll definitely make sure that lecture 2 will be a little bit better, guys. So we're looking at the superior view of the pelvis. So if we were to, this is kind of the same as a bird's eye view. If we were to move everything else but the pelvis, now you can see a few things. First things first, we see what is known as the ischial spine over here. And it's just it's a thin pointed triangle eminence that projects from the dorsal or the posterior aspect of the ischium. Right, so that's 1/3 of the pelvis. And it's found between those two notches we were talking before. So we have that greater notch over here, and we have that lesser notch over here. So the greater sciatic notch and the lesser sciatic notch. Okay. We also have a false or a greater pelvis. So this is the red circle over here. It's a bigger circle, but it's not a complete circle, right? Because it's not completely surrounded by bone. This circle starts from the ASIS, so the anterior superior iliac spine, wraps around posteriorly to the other side's ASIS, okay? So it's an incomplete bony circle, but in between it, we have the inguinal ligament that completes this circle, okay? Now, inside of it, we have the true or the lesser pelvis. And this one is called true because now this circle is fully encircled. The circle is fully encircled, man. Got to work on my English. This is fully encircled over here by bone, okay? And having a very small true pelvis has certain consequences for childbirth. This is pretty much the limiting factor for how much space the baby has to move through, right? But if you guys remember from before, because our body releases relaxin, which is able to relax the joint of the sacroiliac, the joints like the sacroiliac joint over here, as well as the pubic symphysis, this canal over here can actually increase in size. Okay, but this is where the baby has to worry about getting through. This is like that final tunnel it has to get through before it's delivered to the real world. Now let's go back to the pubic arch actually. So that's that structure over here. We have a wider pubic arch in females, and it's also a smoother one. Whereas in males, the pubic arch is more narrow and it's rougher. So that's something to think about if you were to compare one pelvis from another, right? So if I were to, let's say, give you a picture of one pelvis and another one, and I would say to you something like, okay, one is male and one is female. This is one clue I'd like for you guys to look for. I'd like you to look at the pubic arch and see which one has a wider one. If it's a very wide one, it's most likely a female. If it's a narrow one, it's most likely male. Also look at the width of the pelvis itself from one iliac crest to another. So a female is going to have a wider iliac, a wider pelvis at the iliac crest than a male. So those are two things I'd like you to look for if I were to say, okay, compare one pelvis to another. Okay, so let's do a quick recap, guys. The pelvis, aka the os coxae, is a general term given to the hip and the pelvic girdle. We talked about how the pelvis is the fusion of three separate bones. We got the pubis, the ischium, and the ilium. And each side has its own set of those three bones. Okay. Now, not surprisingly, the nerves of the lower limb arise above the hip. So we're talking about from the lumbar spine and the sacrum. And they exit through foramens, of course. So we talked about the intervertebral foramen in the spine lecture. Sorry, I have to sneeze. Give me a second, guys. Nope. Sneeze went away. So they exit through the intervertebral foramen from the lumbar spine as well as the sacral foramen. Don't worry about that too much because I'd have to show you the last lecture, but just remember the foramen. Now, the nerves that innervate the legs all originate from what we call the lumbosacral plexus. And yeah, don't worry about this last question. Okay, so this is the scary slide I was talking about, guys. A lot of nerves, a lot of writing. This is the lower body's version of the brachial plexus. We call the lumbosacral plexus because these nerves originate from the lumbar spine as well as the sacral spine. Okay? Very busy slide. I don't want you guys to worry about it too much. Let's go over the general concepts of nerves again. Okay, so remember, nerves innervate to cause two things. A, they cause motor signals, meaning that they send electrical information to the muscles to contract, right? So if we want to, let's say, extend our knee, our brain has to send signals to our quads to cause that muscle to contract to extend our knee. Okay, cool. The nerves also have to receive sensory signals from, let's say, our skin and send it back to our brain. Okay, so we got motor nerves and we got sensory nerves. Awesome. Okay, these red arrows over here to the left indicate all the nerves that have mostly motor function. The ones without the arrows, so this one over here and this one over here, is predominantly a sensory nerve. Okay. And if you look at the rightmost part of this diagram, we have all the nerve roots. So we have L1, L2, L3, all the way to S4. So they correspond to these levels over here. The lumbosacral trunk pretty much refers to the unity between the sacral nerves, so S1 to S4, and the lumbar nerves, so L1 to L5. Okay? So let's start from the top, guys. We begin with the lateral femoral cutaneous nerve of the thigh. And I'll write this down for you. Femoral cutaneous nerve of the thigh. Boom, right there. So you can see that it kind of originates from the topmost nerve roots, I would say L2 and L3. So what happens is nerves tend to be the result of multiple nerve roots, right? So they branch and they turn into one specific nerve. Okay. This nerve actually receives sensory signals from the skin on the lateral part of the thigh. So if you guys were to rub kind of the outside of your thigh, you would be activating the lateral femoral cutaneous nerve. Okay. The clinical implication of this nerve is that it is commonly compressed because it's actually a very superficial nerve. It's taking all those sensory signals from the outside of your leg's skin. So common ways to compress this nerve include tight clothing. So those guys that wear skinny jeans or women that wear skinny jeans, bad idea. You're compressing this nerve. Another couple of reasons include weight gain. So maybe not the pants getting tight, but maybe the legs getting big. And pregnancy. And what this does is it leads to a condition known as neuralgia peristatica. So neuralgia peristatica. Okay. This is a condition where you start losing sensation on the outside of your legs, or you get a lot of pins, needles, numbness, tingling that just doesn't want to go away. So the solution, stop wearing tight clothing. Especially for the lower extremity guys, I'm going to be bashing a couple things. One of them being tight clothing, another one being high heels. All right. So I'm not going after the lady specifically, but high heels, oh my God. When we get to the foot portion, guys, I'm gonna destroy heels. I'm gonna make you wish you never wore heels. Okay. So stay tuned for the foot lecture because heels, very bad, very bad. All right, so that's the lateral femoral cutaneous nerve of the thigh. Okay. The next one is a very important one, and that's the femoral nerve. So the femoral nerve, if you see over here, originates from L2, L3, and L4 nerve roots. So a great way to remember this when you know the activation of these nerves is that L2, 3, 4 kicks the door. I'm going to write that down. L2, 3, 4 kicks the door. So you need your L2 for hip flexion. You need your L3 for knee extension. You need your L4 for ankle dorsiflexion. All those movements help you kick a door. And we'll talk about that in a bit anyways. But that's just a great thing to kind of put in your back pocket for now so that later on we can remember where these nerves come from. Yeah. So the femoral nerve pretty much activates all the muscles on the anterior leg. So we're talking about your quads, your hip flexors, and the anterior shin muscle, aka the tibialis anterior, which we'll talk about later. Okay. Now, I hope we're doing okay so far. We got the obturator nerve as the next nerve that emerges from the lumbosacral plexus. It also has origins from L2, L3, L4. If you look at the diagram over here, so it branches off to L2, branches off L3, branches off L4. This takes care of primarily the medial muscles of the leg. So we'll talk about the abductors of the leg in the next lecture. We're talking about the muscles near the groin, basically. So if you guys know where your groin is, those are where the muscles are that this obturator nerve would innervate to cause motion. Okay, moving on. We got the superior gluteal nerve, and its origins are from L4, L5, and S1. This nerve emerges posteriorly, so it comes up from the back of the leg, and it's named based on where it comes out of. So it comes out of the superior gluteal notch, or the greater, sorry, not the superior gluteal notch. Sorry, scratch that. It's superior gluteal because it's superior to the inferior nerve, and it goes posteriorly to the posterior muscles of the glutes, and it innervates some of the glute muscles. So we have a lot of glute muscles, meaning this gluteal nerve will innervate it. And if we have a superior gluteal nerve, that means we also have an inferior gluteal nerve. The inferior one has origins from L5, S1, and S2, if you look at where the branches come from. Okay. Now, we have the nerve to the obturator internus and superior gemellus, L5, S1, and S2 origins. And this nerve is basically named based on the muscles they innervate. So obturator internus is a muscle in our glutes, and the superior gemellus is a muscle in our glutes. And we're going to be talking about that in the next few lectures. And then the nerve after that, same idea, nerve to the quadratus femoris and inferior gemellus. And it has its origins in L4, L5, and S1. Again, named after the two muscles it innervates. Okay. And we have another sensory nerve over here called the posterior cutaneous nerve of the thigh. So I'll write that down. All right, that's the one in pink over here. Has origins in S1, S2, and S3. And this nerve over here gives us the sensory information for the skin on the posterior aspects of our hips, aka our butt. So this nerve is responsible for helping us know that we're sitting on our butt right now. Okay, it's a nerve that's also going to tell us to kind of move our position while we sit, so that we're not spending too much time compressing on, one muscle. That's why we move a lot when we sit, guys, because if we sit in one position too long, you're going to actually cause really bad compression on all the structures underneath. So this nerve kind of tells us where we are in space with our butt, and whenever we do feel discomfort, it signals us to kind of move somewhere else. Okay. And we got the last most important nerve over here called the sciatic nerve. And I'm pretty sure most people are aware of the sciatic nerve. It's the biggest nerve that comes out of the back of the leg. It's the one that's implicated in sciatica, sciatica being the compression of the sciatic nerve, which leads to symptoms like low back pain and posterior leg pain. Okay. If you guys have ever had sciatica, it's a very annoying thing, but it's a very fixable thing too. And there are a few causes of sciatica that we're going to touch upon later on. But you can see in the coloring over here, it's actually made up of two separate nerves that kind of join together in a covering called an epineurium. Don't worry about, what an epineurium is. But, as this nerve travels down the leg, it actually separates into two smaller nerves as well. Okay. So, busy slide. Use it as a reference. Again, don't get caught in the details. Since this is more of a general anatomy course, if I were to write a test, I wouldn't ask you details like if we were to, let's say, if I were to ask you, what are the nerve roots of inferior gluteal nerve? I wouldn't ask you a question like that. You'd have to tell me L5, S1, S2, right? How is sciatica fixable? If you have time to answer, of course. There isn't enough time to answer, but generally speaking, sciatica is a result of compression of the sciatic nerve. It could happen for a few reasons. There could be inflammation in, let's say, your hamstring region, or any part of the path of the nerve where compression happens because of the swelling from inflammation. It could also happen from piriformis syndrome, which is a muscle that the sciatic nerve actually travels through. So a lot of times I find sciatica happens because people spend too much time sitting, and so their hamstrings get really tight. Another reason you get sciatica is that you fail to learn how to use your glutes. So the piriformis muscle actually works a little too hard. So another way to fix sciatica is by strengthening the glute muscles, right? Like your gluteus medius, your gluteus minimus, and even your gluteus maximus. Those are all ways you can kind of address sciatica. And it depends on how bad the sciatica is, right? Me as a therapist, I use a lot of nerve gliding techniques. So what I'll do is I'll manually get the sciatic nerve to move, kind of like floss through the tissue to loosen it up. There are different ways to address sciatica, but it's a very fixable problem, actually. Okay. You know what? I'm not going to touch into these just yet, guys, because we only have a few minutes. I want to touch upon this in the next lecture. Let's see. Yeah, because we're going to get into the ligaments, and the ligaments are actually pretty detailed, and we still haven't talked about the back of the pelvis yet, so I want to touch upon that. So we'll stop at the lumbosacral plexus for now. What I might do, guys, is I might give you lecture slides that start maybe from this slide for next lecture. Let me just take a look at what we're talking about for next lecture real quick. So next lecture, we're going to be talking about anterior medial thigh musculature. So we're going to get into the thigh muscles, so your quads, muscles in your shin, how they work, how they activate, what movements they cause. So that will be the plan for next lecture. In the meantime, this is the beginning of lower extremities. I'm glad you guys can all tune in. If you do have any questions, I'll be here to discuss them. I know this was a pretty heavy lecture towards the end. So if you guys do have any feedback about, talking about the nerves like this, I'd like to know. Just for future purposes, if I plan to talk more about the nerves, I want to kind of get your guys' feedback and see what you thought of me talking about all the nerves that originate from the spine. If it's a little bit too dense, or if I could have gone into more detail. Yeah, let me know. I mean, I'm always trying to improve the lectures as well. Otherwise, yeah, that's the end of lecture 1 for semester 2. So good job, guys. You guys did really well with the questions, by the way. I'm really proud of you guys. You guys obviously got better since semester 1, so I'm happy about that as well. If you have any questions at all, I'll be here for the next 5 to 10 minutes. Otherwise, peace out. We'll talk on Thursday, and we'll be talking about the muscles of the thigh.